Welcome, and thank you for joining us for Nerve Flossing and Collaborative Care with Edward Walsh. In this session, Edward shares practical techniques and key insights to support better decision-making with your doctor. To continue this conversation, we invite you to join Edward's companion group on our website. You can scan the QR code or go to acmcrn.org/groups.
Edward Walsh graduated from Plymouth University in 2017 with a degree in physiotherapy. In his early career, he rotated through respiratory, neurological, and musculoskeletal care before specializing in orthopedics. He went on to help develop a clinical pathway for patients with low back pain suspected of having cauda equina syndrome, which overlaps in some ways with adhesive arachnoiditis. Edward later completed a master's degree in neuroscience, strengthening his understanding of complex neurological conditions. In addition to his clinical work, Edward shares articles and reflections through his professional blog at edwardwalshphysiotherapy.com/blog. With this background, Edward now brings his insights into managing chronic pain. Let's join him as the presentation begins.
As I say, I had to think quite hard about how what I have learned in my clinical practice could be potentially helpful for people with adhesive arachnoiditis, bearing in mind that this specialty sort of pathway that I've gone down is more musculoskeletal rather than neurological physiotherapy. Okay, so the condition itself, so again, I appreciate there'll be some people on this call who know this very well, but I'm just going to cover it in brief because it directly links on to what I'm going to be talking about in terms of a possible treatment strategy. So in adhesive arachnoiditis, I learned that essentially it's a sheath around the nerves in the spine that becomes irritated, inflamed, and then as a result of that sheath becoming irritated and inflamed, that inflammatory process causes those nerves within the spine to bunch together, to become clumped together, and then those nerves can't actually function as well as they normally would. And this is what causes, if it's in the lower back, those symptoms coming down into the legs, but also symptoms that can, for example, affect the bladder, etc. And you can see quite clearly here on MRI a view of nerve roots inside a spinal canal, as you would expect on the left, where they're very distinct, and on the right, in the case of a case of adhesive arachnoiditis, where those nerves that have been that were very distinct have clumped together, and as a result they can't function in the normal way, and that's what causes a lot of the symptoms, including the pain. That's one of the big pain drivers in adhesive arachnoiditis. So this is quite a nice image showing the progression. So the reason it's called adhesive arachnoiditis is the layer, the sheath that covers the nerves that gets irritated and inflamed. The one that causes the issue is called the arachnoid layer. And when that gets irritated and inflamed, there is a almost like gluing together of those nerves and that layer, which is what causes the bunching. So it's an adhesing, so a gluing together, a coming together of these structures where they don't separate fully, and that can harden over time. Scarring occurs, and those nerves can get quite fixed in that area. Again, I appreciate a lot of you know this, but I'm just outlining it as it links on directly to the treatment side of things that I'm going to talk about in the slides to follow. And I came across a few different categorizations for adhesive arachnoiditis. This is one of the suggested categorizations. And I think one of the things I noted, which I think is a bit of a challenge currently, is if you look at that mild adhesive arachnoiditis full motion, no back indentation, normal inflammatory markers, no bladder impairment, no MRI evidence of spinal fluid leakage or obstruction, no hormone abnormalities, and can sit or stand in one position for 10 minutes. If that's a criteria for a diagnosis, that becomes very hard, I think, as a clinician to go, how is this any different from somebody who's coming in with low back pain, which is incredibly common? You know, how based on that presentation, what is there to say that this is not just generic low back pain rather than adhesive arachnoiditis? And this is problematic, I think, because the sooner that this can be addressed within the process of it happening, generally speaking, the sooner you can get to things, the more effectively you can treat or manage them. So I think there's some interesting work to be done here in the early stages about identification, and I'm sure Laurie maybe could speak more to that later on after the talk. But I think that's one sort of very interesting area when it comes to adhesive arachnoiditis. And then towards the more severe end of the diagnostic criteria, there are really impairing symptoms that massively impact on life. So difficulty dressing, eating potentially, difficulty with moving, so either needing a mobility aid or potentially needing a wheelchair, difficulty with bladder issues, so urgency, incontinence. There's mental deficiencies listed in there. Now, I don't think that has anything to do with the actual process of adhesive arachnoiditis itself. I don't think it has anything to do with the bunching of nerves within the spine. It has, I think, probably much more to do with the fact that there is an immense amount of pain and difficulty that's associated with getting this condition. And as a result, the cognitive capacity, the reserve that your brain essentially has for some of the more difficult cognitive tasks is going to be reduced. I would make the case. I think Evelyn's just put a point in there about pressure in the spinal cord. That's a fair case as well. That's interesting. Yeah. But certainly with regards to pain, when pain is really high, we know that cognitive functioning is tricky because it can be totalizing. And you've got these other symptoms in here as well. So elevated inflammatory markers, hormone abnormalities, really severe pain, clear evidence on MRI, and there's inability to sit or stand in one position for 10 minutes. So it's really a debilitating condition. So I think the word priority is often misused in common parlance. We have this idea of priorities these days, but that's never actually how the word was intended to be used. A priority it was supposed to be, in the original intention of the word, a singular thing. So one thing that is more important than everything else. And I think when I was learning about this, I really tried to identify what is the key piece of information I think that needs attention really focused on it. And there are a number of different sort of avenues that I thought were initially quite interesting, but this is the key piece, I think, that's really important to get across. It's that it can take 6 months before adhesive arachnoiditis shows on MRI. Now, why is that critically important? I think this is important because unfortunately, when it comes to adhesive arachnoiditis, there are going to be clinicians. I myself hadn't heard of adhesive arachnoiditis until Laurie reached out to me. Okay, so my knowledge base was poor. I don't think I'm the only one who's going to be lacking a complete knowledge of this process. But here's why this is so important. If your treating clinician understands that in order to diagnose an issue, a scan needs to happen at a specific time point, they will adjust their reasoning based on that. And we do this already in practice in other areas. So, for example, we know when it comes to the wrist, there's a bone in your wrist called your scaphoid, okay? And if you fracture that scaphoid bone, we know that actually on the initial scans, it doesn't always show. And so there are protocols that are clear to professionals who work with people who have these sorts of injuries, that if you're suspicious that there could be an issue with this bone, then you scan after a certain time period where we know it will actually show up on the scan. Okay, and the consequences of not picking that up are very problematic further down the line. So this has been highlighted. We're aware of the issue, and this is protocolized across areas where people deal with these sorts of fractures. With adhesive arachnoiditis, and with low back pain more generally, if somebody came into me complaining of, and I was seeing them in clinic, in my day-to-day practice, where I see people with back pain and where I see people with back pain with nerve-related back pain as well, and I was concerned about some of the features that they were explaining to me. So if they were saying, I have this back pain, I also have these symptoms coming down into my legs, for example, these nerve-related symptoms, and I was concerned, and I thought it warranted further imaging, and I referred them on to a doctor who referred them to have an MRI, and that MRI came back and showed that actually all of the nerves looked okay. Before learning about adhesive arachnoiditis, my decision-making process and my clinical reasoning would at that point be looking at alternative explanations for those symptoms, because I would be unaware that actually it could take 6 months to show on an MRI. And so this is where I think it's going to be really important, as somebody advocating for oneself in a clinical encounter, to help the healthcare professional help you, essentially. And it can be challenging sometimes to have those conversations with healthcare practitioners, and sometimes there can be a bit of a power imbalance. But I think being aware, thinking about how you're going to approach that conversation, and then having a collaborative conversation with the healthcare practitioner that you're seeing, can be really, really helpful. Because a good healthcare practitioner, any good healthcare practitioner, is, when they're clinically reasoning, they're thinking about their clinical knowledge, they're thinking about the research base, but they're also taking into consideration what you're telling them. And so if this is an area where they may have a bit of a knowledge gap, I certainly did, I think this is a really, really important point to make sure that your healthcare practitioner is aware of, when they're, if you're suspicious that perhaps you have adhesive arachnoiditis. So yeah, this is the priority key piece of information, I think, that will potentially have quite a big impact in terms of individual cases, in terms of how this is managed, how effectively this is managed, and how quickly this is managed. And I think maybe it's something to think about again when some more of this work has been done. So as I said, with the scaphoid fractures, it's just part of protocol. Like, it's just very well known that this is what needs to happen. With adhesive arachnoiditis, I know I've spoken with Laurie, and the suggestion that adhesive arachnoiditis is rare is actually being challenged a bit by some of the more recent research being done. And if it is shown actually that adhesive arachnoiditis is more commonplace, then it might be something worth pushing, I suppose, more towards clinicians. But in the interim, while that's still happening, I think this is the time to be prepared going into those consultations, and to advocate for yourself, and to come to your assessment and treatment plan in a very collaborative way with the person who you're interacting with. Okay, so that's the really key priority piece of knowledge. This graphic is taken from some work that Laurie did, as you can see with others there. And it was asking people with adhesive arachnoiditis, what treatments have you tried? What have you found effective? And what have you found didn't help or actually made things worse? And there are a couple of things I think that are really interesting in this graphic. One is that, well, I think the first thing that shows through is actually that they're really, none of these treatments are shining through as really, really, really effective. And I think that's the sort of first thing to acknowledge looking at this. This is a tough condition, and there is no sort of head and shoulders standout treatment, which I think is tough. And I think that's quite sad. The second thing that I noted with this, in terms of these responses to this survey, is that the treatments that seem to be the most effective of the lot are opiates. So you can see here in terms of the effectiveness, the things that are coming up as most helpful. You've got morphine, fentanyl, oxycodone. These are all opiates. And there is a huge amount of discussion at the moment with regards to these. The downsides to opiate use and opiate prescribing have been talked about at length, particularly in relation to the US. And it's been something that has been, widely discussed, I would say, in the last few years. And those downsides have been really highlighted. But there has also been some discussion from people who have pain conditions of varying kinds, who, as a result of some of the changes made following discussion about the downsides of opiate use, are now no longer able to access opiate medications from their prescribing doctors that were actually really helping them manage their respective pain conditions. And so it's a complicated area, but I think the thing that is very clear from this survey is that these opioid treatments do seem to really help with adhesive arachnoiditis. And so again, I think this is something that can be potentially helpful in coming to those collaborative treatment decisions with your treating healthcare practitioner, and showing them, look, actually, this is what appears to be quite helpful for people with adhesive arachnoiditis. It's a very, very complicated area, and there's difficulties because there are pressures all over the place in terms of opioid prescribing. And so in some cases and in some countries, doctors are being highly disincentivized to prescribe opioids. So it's a complex one, with sort of policy and disincentives all sort of tied up together with the clinician's clinical reasoning at the time. But I think this is a very, very helpful bit of information that can be used to reach an effective collaborative treatment plan. The final thing I think that I found really interesting from this, and a bit disheartening, is that the vast majority, or rather more people who tried physiotherapy found that it actually made the situation worse than found that physiotherapy helped. And obviously, as a physio myself, that's somewhat disheartening. And certainly, I think if it's just the case that physio doesn't help with a certain condition, then I think, we get out of the way and we whatever treatment works, right? But I think physiotherapy is very broad. There are a number of different treatment approaches therapists take with people with different conditions. And so again, this forced me to scratch my head and really think, okay, what could be a potentially helpful strategy, a specific strategy that people with adhesive arachnoiditis could trial and see if it worked for them. So Laurie actually sent me this as well. So Laurie's been incredibly helpful in prepping for this and guiding me towards some useful research. So this was a case study that was done actually by, I think, some chiropractors for somebody who had adhesive arachnoiditis. And what the treatment approach that they tried was nerve flossing. So this is their description of what they did to try and help this person. And you can see there, they said the intent of the intervention was to reduce nociception, assist the desensitization of the lumbosacral nerve roots, and mobilize the periadicular adhesions, which is a sentence with a fair amount of medical jargon in it, but it's actually quite interesting. So what they're attempting to reduce nociception, which are signals from the nerves that potentially indicate tissue damage. They're not quite pain signals, but you could think about them like pain signals. Assist the desensitization of the lumbosacral nerve roots. So those nerves that are clumping together that are causing pain, essentially trying to turn the volume knob of that pain down, and to mobilize the periadicular adhesions. So that is essentially trying to loosen off the glue that has stuck all of those nerves together that we saw earlier on. And they're very specific in that they try to apply tension to one end of the nerve while slackening the other. Okay, so this is an interesting approach. That's what makes it a nerve floss, by the way. It's tightening one end while slackening the other. So I just want to say at this point that I have put together one blog that explains how to do this nerve flossing technique, so that the bits that I go through today and the videos I show you, don't worry about trying to remember it all, trying to scribble it down, because you will have access to all of this afterwards. Those videos are up there, and it's a guide on how to do this nerve flossing approach. Okay, and I'm sure I can share that with you all afterwards. This nerve flossing approach is very interesting because of this proposed, like you're flossing your teeth approach, but with the nerve. And it sounds great, but I had some questions. So I went to the research. The first question I had was, this sounds great in theory, like it sounds like a really nice concept, but physiotherapy has a bit of a history where we come up with theories about how the body works and interesting concepts, but when we actually come to research those ideas, they don't stand up to scrutiny. So my first question was, does this flossing approach actually work? Like, can you do that with a nerve? And is it different from when you pull it and actually cause tension on either end at the same time? And luckily this research has been done, and the answer is yes, basically, in a nutshell. When you can actually move a nerve such that you pull it from one end at the same time as loosening it on the other, and pull it back the other way and then loosen it here. So you get this nice smooth movement of the nerve, which doesn't increase tension. Whereas when you tension a nerve from both ends, you don't get so much movement, and you also drive the tension up, which can be uncomfortable. The second question I had was, does it actually help people? So, okay, it seems like this approach, the concept fits with what actually happens with the nerve. Does it actually help people who have nerve-related low back pain? And in this summary of studies where they pulled all of the findings from different research that had looked at how this nerve flossing helps people with nerve-related low back pain, they found that it was very effective. So this is a good outcome from the research, where they grouped all of these trials together, looking at how this sort of a treatment can help people with nerve-related low back pain. Unfortunately, we don't have this sort of data for people specifically with adhesive arachnoiditis. That research just hasn't been done, and that's why the reference is to a case study of one person. But we can see from conditions that are similar in some ways to adhesive arachnoiditis, where potentially a nerve root is getting irritated and causing nerve-related low back pain, actually this treatment approach is effective. And then the other thing that I wanted to look at was, okay, so we know that you can actually floss the nerve, and we know that it helps, but is there a way of doing it that is the most effective? And so this was an interesting study where they looked at different ways of trying to get the nerve moving. And then they actually used dynamic ultrasound on the back of people's legs, so that they could look at what the nerve was doing and see how much the nerve moved. And then they identified the way that was most effective for getting the nerve moving. And it was actually image A out of these 4 images. So there is a way of doing it that is most effective as well. And what I was really impressed by in the case study that I shared with you earlier is they shared videos of how they carried out the nerve flossing for the person that they were treating with adhesive arachnoiditis. And those are the videos that I have shared as well with reference to the original study in that blog post. So that can be directly replicated by yourselves if you want to give this a try. You can do it exactly like they did in the research, and the way that they did it in the research is a really effective manner for doing this flossing. So the technique is good, basically. Okay, so I've got some videos here. Let's see if this plays or not. That's just drawn a green dot on it, so that's not actually achieved very much. Let's have a look, see if I can get this to play. Maybe if I do this.
This is a demonstration of patient-generated or self-care sciatic nerve mobilization. To begin with, have the patient seated comfortably, maintaining a normal lumbar lordosis along with a neutral head position. Have them first begin by extending their leg at the knee along with dorsiflexion of the foot, while simultaneously extending the cervical spine to a comfortable position. To return, have the patient flex their knee back to the original position while simultaneously flexing the cervical spine or tucking their chin to their chest. This is patient-generated sciatic nerve mobilization.
Okay, so very good technique. They explain it slightly out of sync with how the movement should be done. So it should all be one smooth movement in terms of what you're doing with your neck as well as what you're doing with your knee. But that's it. That's a really good demonstration of the technique. I'm also now going to show you a video of how it can be done in lying as well, so that there's that option available also.
Today we're going to be demonstrating distal and proximal sciatic nerve mobilization. To begin with, have your patient lie supine on the table with their head in a neutral position. You, the practitioner, will grab the affected side leg along with dorsiflexion of the foot, raise the leg in a straight leg raised position to the point where you feel a barrier of resistance. It is ideal to perform this maneuver at the barrier, although if the patient experiences sciatic nerve symptomatology before the barrier is met, it's ideal to only work from the point of symptomatology. At this point, have your patient slowly flex the cervical spine or tuck their chin to their chest while simultaneously plantar flexing the foot. Have the patient lower their head back down to the neutral position while simultaneously dorsiflexing the foot. That is distal sciatic nerve mobilization. To perform the same maneuver proximally, once again, grab the affected side leg along with maintaining dorsiflexion of the foot, raise back up to the barrier of resistance, have the patient flex their cervical spine slowly, and instead of plantar flexing the foot at this point, we're going to lower the leg or extend at the hip. Have the patient lower their C-spine back to the neutral position while simultaneously raising the leg back up to the barrier or flexing at the hip. This is proximal sciatic nerve mobilization.
Okay, so and with that one, what I would say is, yeah, if you've got somebody there who can help you with this and can do that with you, great. If not, you can do it yourself with something like the waistband from a dressing gown. Okay, and so rather than another person with their hands doing those movements that the chiropractor was doing there, you can do that just using some support from, for example, the waistband of a dressing gown or something similar. Okay, so you can do that yourself even if you don't have somebody else there to help if you want to practice that lying one. As I say, these are all of these videos are going to be available in the blog. Okay, but what I think is really really positive about those videos is the technique they show is bang on. It's really good technique for flossing the sciatic nerve. So I thought it might be quite interesting that we all give this a practice. I think maybe we'll do that at the start of the Q&A, and we can talk a bit about that once we've finished this talk. But I'll round it off here, and then we can move on to the questions and maybe giving this a bit of a practice now where you are, which is the research hasn't been done yet, right? So we don't know based on the available research whether this will be a really helpful technique or not. But based on the fact that adhesive arachnoiditis, the core issue is a bunching of those nerves, based on the fact that in this case study, so it's only one person, but one person with adhesive arachnoiditis, they did this treatment for 3 weeks. They didn't even do it daily, and they just did it a few times a week for 3 weeks, and the person had a reduction in the amount of pain they felt on a 0 to 10 pain scale by 2. So I can't remember what the score was initially and what it dropped to, but the pain score dropped by 2 on a 0 to 10 scale, which with 3 weeks of not even daily practice is worthwhile doing. Generally speaking, the sort of pain severity changes that people notice and they say, actually, yeah, this is like worth doing, is when you have a change on that scale of about 2 out of 10. That's when people notice the difference in terms of the pain that they're experiencing. So it certainly helped one person with adhesive arachnoiditis, and it seems to fit in terms of how it would help, because the central issue is this bunching together of nerves, and because this gets those nerves moving, but in a way that you're not increasing neural tension. So that is everything that I had to talk about today. We'll give it a bit of a practice now, and I would be very happy to answer any questions.
Well, thank you, Edward. That was an insightful presentation. So before we move into the Q&A, I want to go ahead and present a couple of things to you. And then after that, I'll turn on everybody's microphones and cameras. So can you, let me see, stop presenting, Edward, so I can hopefully present what I want?
Yeah, let me stop sharing now.
Let me see. Okay. All right, so does everybody see that? That's our website. And this is our community hub on the ACMCRN website. Did that go away? There it is. This is the place where you can find recordings, such as the recording of this workshop, connect with others, and join in discussions. And when you choose the group option from the community hub, you'll see hang on a second. Oh my goodness, I lost my notes. Okay, so this is, we set up a number of groups, including one just for today's session with Edward, and you'll see it right there. It says Managing Chronic Pain, Expert Insights with Edward. You can choose to join this group, and we'll place the recording into this group area, and we can continue the discussion after this workshop. Everybody's welcome to go there. And this will be in addition to Edward mentioned the blog where he's also going to put the recording up, and we'll be sure to put a link to that there and also to his website. So with that, we'll move on to the questions, and let me stop this presentation. Open up, hopefully, everybody's microphone and video. Everybody, are you able to turn on your cameras and your audio? I see you, Lori. I don't see anybody else. Oh, there's Linda. Oh, there's Linda. Hello. Okay, so this part of the session, the Q&A, is not going to be shared publicly. I'm going to continue to record it, but I'll edit out this section. So go ahead and don't worry about the being recorded for this particular portion. So with that, you can drop your questions into the chat box there, or you can ask them and from the, with your, go ahead and talk. And Edward can answer the questions. So does anybody have any questions? Go ahead.
Linda.
Okay. Hi. Can you hear me?
I can, yeah.
Thank you. Edward, thanks so much for a lovely presentation. It was nice that you were able to walk us through both the kind of the physiology of arachnoiditis and then how it hooks up to the neural mobilization, to the flossing idea. I really enjoyed your presentation, and I think that a lot of people are going to listen to this and really benefit from the idea of this. And I also want to just say that it's lovely when we can find some simpler, easy to execute practices that might really have a possibility of bearing on the potential for reducing pain in what is otherwise kind of a sticky situation that's kind of intractable. So all of those things are I think very hopeful, perhaps, to our group, and I'm sure you'll get a much bigger audience than we have here just at this moment. So I think part of this is due to the London versus US time zones, and I know a lot of people are going to tune in later. I do have one maybe simple question. The idea of being able to do some exercises that don't specifically tension a nerve. In other words, we have a lot of ideas and science about tensioning an already inflamed nerve, really having the potential to increase pain. And perhaps that's part of the reason why in physio, in some people's experiences, actually like overexertion of any kind really can aggravate instead of improve the pain. And so if there were, if a lot more physios became informed about the need to not overexert and the need to try to gentler exercises that don't tension the nerve. And I was happy that you really pointed out that to not tension the nerve, you have to, tense one end but relax the other, and then alternate those. And the flossing really is a good demonstration of that. I wanted to mention that some of our members also don't, we have people that have, probably the majority do have lumbar arachnoiditis. And so this idea of working with the sciatic nerve as an excellent example of, how you might actually stretch the nerve roots is great. We have others who also have cervical or thoracic arachnoiditis. And so at one point in time, maybe 5 years ago, I wanted to learn more about neural mobilization as well. And I happen to have more cervicothoracic involvement. And so I became aware that you could do things. And it seemed to me that at that time, at least, most of the literature on flossing emphasized the fact that it was mainly useful for, people that had peripheral neuritis, that it worked on stretching peripheral nerves, whereas in arachnoiditis, sometimes we have more like spinal nerve root or more central involvement than peripheral involvement. But I like the idea of this, and I'm wondering maybe if in future sessions you might also explore, what you could do with, say, the shoulders and maybe ulnar nerve or brachial plexus type of stuff. So I just wanted to basically say thank you, and that we're happy to know you and happy that you're bringing this program to us. Hopeful that, there could be some simple measures, and maybe as more physios become reminiscent of the idea that if you can work our muscles and nerves, but without adding tension, this sounds like a very useful therapeutic approach. So again, thank you for bringing this program to us.
Yeah, that's great.
You're most welcome, Linda. Some great points. Yeah, the last thing anybody with adhesive arachnoiditis needs is more pain. Unfortunately, physios sometimes can cause more pain. And sometimes that's helpful, depends on the condition. Sometimes no pain, no gain, but this is not one of those times. I think one of the things I should actually probably have made clear during the talk, and perhaps this can be communicated to the wider group if they're going to try this based on what we've talked about today, is that with this technique, if you're starting to get symptoms coming on and you're just going part of the way through range. So for example, if you're straightening your knee and you're getting to there, and then you're starting to feel your symptoms, you don't push past it. So you don't go through the full motion. You go up to the point where you start to feel it, and then you come back. So even if that's just a small extension and back for you, that's it. Like, you don't push through it. So that's actually a really important clarification point, which I should have made actually during the talk, and perhaps that can be communicated to people if they are going to give this a go. It's just working within the comfortable range, because the idea is not to wind the nerve up more. So that is actually quite an important point. Can this be done with other nerves? Absolutely. Yeah. So there's nerve flossing techniques for the femoral nerve, if that's actually what's more affected in the leg versus sciatic, and also for your radial, ulnar and median nerves into your arms as well. So definitely these flossing techniques can be approached, and if you know which nerves are affected for you, then you can target those more specifically. With regards to your central versus peripheral nervous system point, so you've got your spinal cord, obviously, which is just going down the middle, which is your central nerve, right, coming straight from your brain. And then what's commonly affected, at least from my understanding with the adhesive arachnoiditis side of things, is the nerve roots, right? So it's that sort of transition point where the nerves are actually coming into the peripheries and supplying either your legs or your arms. And it gets a little bit confusing when you go below a certain level in your spine, because the spinal cord is no longer technically your spinal cord, although it still is kind of central. So this sort of like central peripheral thing can get a bit weird once you go below like a certain level in your spinal cord. But it would appear that the approach is helpful for arachnoiditis based on this case study. So although it's not loads to go on, this is a decent like case study bit of research which shows that at least in one instance this has been helpful. Will this definitely help people with adhesive arachnoiditis across the board? I don't know. I think it's too early to say. And it will be interesting. It will be interesting to see whether it can be helpful. But if it is going to be helpful, I think there's two things. I think one is making sure that you are doing the right nerve floss for the nerve that's affected for you. And so for a lot of people, it's going to be sciatic, but not everybody. And the other thing is not pushing if you start to get the symptoms. That's a really, really key piece of information that I should have nailed in. So again, knee extension, if it's there and then you feel your symptoms, you come back from that point. So you complete the movement, but you only complete the movement within that comfortable range because it's flossing, because in theory it's going this way and then this way, you shouldn't be getting an increase in that tension effect. So if you are getting a bit of an increase in tension effect, it just means that those structures at the moment are a bit too sensitized. You don't push past it. And so thank you. That's a really important clarification point to make.
Thank you for being part of today's session. To continue the conversation, visit Edward's companion group on our website, Managing Chronic Pain, Expert Insights with Edward Walsh. You can scan the QR code on this slide or go directly to acmcrn.org/group/managing-chronic-pain-expert-insights-with-Edward. We look forward to connecting with you there.